Good morning, everyone. Welcome to the conference. My name is Chris Farmer. I'm a critical care physician at Mayo Clinic, now Mayo Clinic in Arizona, and it's my privilege and pleasure to be with you today. We're going to speak today about a critical care topic, and that topic will be improving patient safety and quality in the intensive care unit. This is a very important topic. It's something that will benefit from some further discussion, and I'd like to talk through some basic issues of that today. So let's go ahead and get started. We have several discussion points that we would like to review today with you in the audience. The first deals with our culture, and our culture is one that says change does not apply to me. We don't need to make changes. Everything I'm doing is just fine the way it is. If you want to change something, talk to that person. That's the one who needs to change. In human nature, we say that everything is okay. We say that we don't need to make these changes even if we know that it'll make a positive difference. We also know that human factors contribute. We believe that if we talk to people enough, that if we have more lectures, that if we have more talks, that if we make more signs, that eventually one day they will wake up and they will understand, they will see the light, and they will do a better job. But in fact, this is not how we fix things. We change the actual processes so that errors cannot occur, and we'll talk about that. And then finally, we'll discuss how we make these changes permanent. Many times you have individuals who have high levels of energy and they make these changes, but when people go away, the change also goes away. So let's start first talking about patient safety and what I refer to as the mom test. This is all about your mother. So think about your intensive care unit. If your mother becomes a patient in your intensive care unit, how would you answer the following questions? Does it matter how experienced the doctor is? What if they've not done very many intubations or placed central lines or do not have experience with difficult medical decisions, and your mother has septic shock and multiple organ failure? Are you okay that they're still learning too and that no one with experience is present? Do you have the same expectations at 2:00 p.m. in the afternoon that you have at 2:00 a.m. in the morning? Do you expect better patient safety measures for your mother than you do for other ICU patients? My mother is special. She deserves special care. And what about those people who are the trainees, the learners who are present in the ICU? How do you expect them to be supervised regarding the care of your mother? There are some universal things that we should not forget. And I've summarized these here on the slides, and these are some nice expressions. The problems that we have today arise because of yesterday's solutions. That if you cut an elephant in half, it does not produce two small elephants. It's just another problem. Cause and effect are not closely related in time and space. So sometimes it's difficult to see those relationships that may link these two things together. People often do better before it becomes worse. So sometimes your optimism that things will automatically improve or will naturally get better is wrong. Small changes can produce big results, but the areas of highest leverage are the least obvious. For example, hand washing and how we might change the flow in and out of an ICU to facilitate hand washing, as opposed to hanging signs on the wall that says, "Remember to wash your hands." When lapses in quality occur, we have to wonder about how we improve those things. Do we aim at the individuals with our efforts, or do we aim at the systems of care to make it better? Many times bad communications or incomplete communications are the cause of the problem. How do we improve those communications? What about education and failure to recognize and failure to rescue? These three things are often linked together. So let's look at a case that illustrates exactly the point that we're describing. Let's start at the top. A 72-year-old man is admitted for elective neurosurgery to the hospital. After his surgery, he comes to the ICU, and on the second day in the hospital, he is improved, so he is extubated. He no longer requires mechanical ventilation, but it's also noted by the nurses that he has a poor gag reflex, and that even though he's been NPO, nothing by mouth, tube feedings are accidentally ordered for this patient. So on day 4, the Dobhoff tube is inserted for further tube feedings. The patient is still noted to have dysarthria, but is now moved out of the ICU to the ward, where there's less observation and less oversight of his status. 2 days later, someone notices that the patient now has fever. They have increased respiratory secretions. They order a chest x-ray. They order a urine culture, and then they forget to order antibiotics. So this patient obviously has an aspiration pneumonia, and yet the right things are not happening. So finally, the next day, antibiotics are ordered, but only when someone notices that his temperature is now 39.2, his heart rate is increased, he has respiratory distress, and his chest x-ray from the day before demonstrates a pneumonia. All cultures are positive. On the 8th day, he continues to worsen. He returns to the intensive care unit. More antibiotics are administered. Finally, the patient is re-intubated and develops ARDS. The ARDS worsens. Now we're 10 days since the patient's been admitted to the hospital, and things are going very badly. Sepsis is not improving. ARDS gets worse. Now it's 2 weeks. A decision is made not to pursue dialysis for this patient and not to go further. And finally, 18 days after his initial surgery, the patient actually dies. So we ask ourselves, how much of this was preventable? Is it your fault? Is it that person's fault? Or perhaps the way the system was designed, it did not pick up the errors and allowed individuals to make mistakes. So to fix these problems, the real approach is not to find the individuals who made these mistakes and be angry with them or try to educate them, but to change the system so that these mistakes can no longer be made, irrespective of the individual who's taking care of the patient. So that defines for us what is patient safety. It is the absence of harm, the presence of quality, and the perception of value. These are the 3 elements that make up patient safety. We also talk about quality, and quality is similar, but is somewhat different than patient safety. Quality talks about clinical acts versus care processes that are aimed at prevention. It is also prevention of bad things, adverse events, and compliance with the rules. So there are some differences in how we administer things so that it's quality and also patient safety. We've also learned over time, and particularly in the intensive care unit, that details are important. And I've listed here for you on this slide many, many things that can help to improve not just quality, but patient safety. But you will notice in particular 2 things are listed in red. And these are the 2 things that we should focus on that have the greatest impact on quality and safety. Let's look at these together. The first is multidisciplinary team-based rounds. All providers who are participating in the care of the patient, the physicians, the nurses, the dietitian, the respiratory therapist, the pharmacist, all of the people who were deciding what happens with this patient are standing at the bedside with that patient at the same time, and they discuss the care plan so that when they walk away from that bedside, everyone understands the care plan and everyone will do the same things. This is how we improve the communications. Another related process also listed in red are the daily goal sheet. So as these multidisciplinary rounds occur, we also write down on a sheet that everyone can see these are the goals of care for this patient for this day. We try to limit these to no more than 3 things so that there will be less confusion. The types of things that we write on the list are specific. We will get the patient out of bed 3 times today to improve their skin care and to improve their mobility. That might be one. A second thing might be that we will do a weaning trial on this patient and try to keep the patient off the ventilator while they are off sedation for at least 1 hour. That might be 2. And the third thing would be that today is the day that we would stop antibiotics for this patient. So specific things that everyone understands and knows what to do. This is how we advance the care plans. Again, both of these focus on improving communications so that everyone has the same thoughts and ideas about what's to be accomplished for the patient. Let me give you another example from the page, and this is a sepsis bundle. This is from Cooper Hospital in New Jersey in the United States, and you can see the holes on this. This actually goes on your name badge so that it hangs from your shirt. Everyone can see it. This way, the nurses, the doctors, the pharmacists, when a patient is admitted to the intensive care unit, everyone has the same list at the same time doing the same things for the patient so that there is consistency and that things are not missed. The appropriate things are done for the patient. We all know what goes on this sepsis bundle, but where is it? Is it on a computer? Is it on a sheet of paper somewhere? How do you know that everybody's doing the same thing? This can also be used in an emergency department so that sepsis care is initiated not just when the patient arrives in the intensive care unit, but when they're first seen in the emergency department. There are a number of things that you can do to make all of this fit together, and you can see that this can be very detailed and very complicated. But we can make this into a very small list like I just showed you on the name tag. So let's look at what happens. Here's a hospital in Memphis, Tennessee in the United States from several years ago that took this same approach. And what you can see is the mortality rate for patients who were admitted with severe sepsis. And the bundle was initiated. And you can see the mortality rate drop down from the baseline of approximately 30 to 40% to consistently below 20% for the mortality. So something as simple as making a short list that everyone uses, the sepsis bundle, makes a difference for our patient. Here's an example of a daily goal sheet. Let's look at this together. It looks at things by organ system, looks at oxygen saturations, it looks at catheters, what is in place, how long have they been used, do we worry about infections, and so forth. So very simple data with check boxes. And then you can see at the bottom of page 2 there, the interdisciplinary team members present. So at the end of rounds, when this checklist is filled out on each patient, the care plan for the day, the daily goals, each person, the nurse, the doctor, the pharmacist, whoever else is involved during rounds, they sign and write their initials at the bottom so everyone can see that there was agreement before you go to the next bed. These simple measures make a difference, in the outcome for our patients. Here are some data. This is intensive care length of stay when a daily goal sheet was started. And you can see that at the beginning of this process, that the average length of stay, not for the hospital, but just the ICU, was between 2 and 2.5 days. But as this was implemented, within a matter of months, approximately 6 months, you can see that there was about a 50% reduction in the amount of time that a patient spends in the ICU. And when you do that, not only is this better for the patient to get them out of the ICU and move them to the next stage of their care, but their exposure risks for infection and other complications that occur in an intensive care unit are actually less. So not only can we track this to decreased length of stay, but we can also demonstrate that this improves mortality as well. In other industries, a common way to track this is called the Six Sigma model. And that model has 3 aspects that you can see highlighted here. One is process improvement, where you look at the current process, and if it's broken or it doesn't work well, how do you make it better? The next is designing a process. If you start from nothing, how would you make this so that it's better? And the third is then managing the process. So let me give you an example. Hand washing. If you look in your intensive care unit at how people perform hand washing, you'll see that maybe 50% of people do this reliably. How can you redesign the process so that the people taking care of your patients do not forget to wash their hands? Do you have people remind them? Do you place alcohol gel at every bedside? There's different things that you can do. When you measure this, you can look at the percent accuracy. In healthcare, most systems function somewhere between a 6 Sigma level of a 2 and a 3. When you buy a cell phone at the telephone store, a mobile phone, the reliability of manufacturing that phone is somewhere between a 6 Sigma 5 and a 6. Down at a level 2, that means that for every 308 telephones that you make, one will not function properly. Now think about that. If this really happened, and how many phones out of the millions that are made that we're taking back to the store, we would never accept that. And yet we accept that for our mothers when they're admitted to the intensive care unit. And even if you get to what we consider a high level of performance, 99.9%, if you related this to flying a commercial airplane, this would be 84 unsafe airplane landings every day around the world, and 1 major airplane crash somewhere in the world every 3 days. So you can see with these examples, we would never accept these kinds of error rates in other areas, and yet we do in healthcare. So if you look at inpatient medicine, and this study was actually published at Mayo Clinic, and DPMO stands for defects per million occurrences. So for every million of something that you do, how many times does it go poorly? And I told you that healthcare in general is somewhere between a 2 and a 3 for 6 Sigma. In this study from Mayo, it was measured at 2.2. And that means for every million times that you do something, 245,000 times something will go wrong. That is approximately 1 out of every 4 times. Why do we accept this in healthcare? Let's look again at hand washing. As I told you, the average compliance in the United States is somewhere around 50%. If we look at organisms that are associated with catheter-related bloodstream infections, like Staph aureus or coagulase-negative Staphylococcus, This accounts for about 60% of these total infections. And about half of those come from MRSA. And we also see an increasing incidence of Clostridium difficile as well as vancomycin-resistant Enterococcus. And yet our hand washing compliance, things that we can do to help prevent this, only occurs about 50% of the time. So how would you redesign a system so that the opportunity not to wash your hands doesn't occur? That people must wash their hands. How would you do that? Well, this is something about hand washing, but it's a lot about leadership and how we do this so that at all levels the systems function properly. You cannot fix these problems as a leader with an email. You must be present. You must have your eyes watching what's going on and pay attention to the behaviors of others and correct them on site. And when people see that there is accountability, that they will be held responsible for their behaviors in changing the system, then this improves compliance with this. So how do you do this? Well, you develop a strategic plan. You know what you're trying to measure so that you can see when things improve, and so forth. Let's look specifically at hand washing in a little bit more detail. We've known this for a long, long time. Semmelweis, over 150 years ago, looked at hand washing, and the first things they studied were in puerperal sepsis. So someone delivers a baby in a mother whose womb, whose uterus is infected, and then they go see other patients and wonder why they get infections and why they get sepsis with these things. And he tracked it all back to hand washing. But ultimately, he was determined or decided that he was a lunatic, and he died in an insane asylum. People didn't listen to him. So we've known this a long time. So how can we make this an improvement? Here's a study that was published about almost 20 years ago from Australia that looked at teaching hospital staff to wash their hands. So initially, you're supposed to do this before you touch a patient and after you touch a patient, so 2 times for each patient. The compliance with doing that was low for patients. Ironically, in this study, they asked the providers, did you wash your hands? They estimated that they actually washed their hands about 75% of the time. So there was this large difference in what they did and what they thought they did. In fact, they were doing. There was an editorial, a commentary that was written with this paper, and I pulled the quote for you to read because it is so striking. And it says that they were astonished that these doctors can be so extraordinarily self-delusional about their behavior. So this is what I'm getting at when we talk about systems change. You cannot change people's behavior if they don't themselves understand and recognize that their behaviors are bad. So the system of change must address how people think about these things and not just hanging up signs and yelling at people when they don't wash their hands. That means for these infection control goals, you must limit the opportunities for failure or non-compliance. This is actually a science, and it's been used in other industries, and we refer to this as human factors engineering. How do we make a cell phone, a mobile phone, without having it break 300 times out of 1,000,000 or whatever the percentage might be for the Six Sigma? The way that we do this is we standardize the process by how we make them so the opportunity, the chance for error to occur is engineered out of the design and manufacturing process. This is the essence of human factors engineering. We do this in banking. We do this in how we fly airplanes. Most industries do this except for healthcare. So as we go forward in healthcare, this becomes very important for us. Let's look at an example of how we might do process redesign. So you see a picture here of a patient laying in a bed, and you can see the flow that's been diagrammed of how someone walks into the room, where they walk around, what they touch, the directions they take, and so forth. So if you were to redesign these processes, for example, hand washing, how would you do this so that error would not occur? And you would change the flow in the room. You might change where the furniture is arranged. You might change where the doorway was, where the hand washing, the alcohol gel is, how they access the patient so that you can't exit the room without walking past the hand gel, that where the nurses work is near to a spot where they can watch what goes on, and so forth. So these sorts of redesigns are very simple, but can make significant differences. So what we're trying to do is make it easier to do the right thing. Let's look at some other examples of how we might do that. The first is hand hygiene. So I've showed you one with adjusting the flow. In other parts of the world, and this is very interesting, where they have access to electronic devices, patients or employees wear an electronic badge. And then there is a laser or an electronic sensor at the door that when you wash your hands with the alcohol gel, it can see that there's gel on the hands. So when you walk past the doorway in this sensor, nothing happens. But if you don't have gel on your hands, when you walk past this sensor, then your name badge lights up and turns red. And everybody can see in the room that you didn't wash your hands. So this is a higher tech approach to this, but can significantly improve the compliance. And a number of hospitals in the United States are doing this. Let's take another example and discuss this. This avoids a problem that in human factors engineering we call inattentional blindness. And let's talk about what that means. Inattentional blindness is when you don't notice that an object or a process that is within a person's visual field, what's going on, because you're looking at other things. So here's an example. A resident comes in to do a central line insertion, and the senior resident is going to teach the junior person how to perform this procedure. So what is their focus? Their focus is on the landmarks. Here's where the clavicle is. Here's where you place the needle. You want to aim it this way. You turn it that way. You watch for these things. So your focus is all on these things. But because your focus is here, the inattentional blindness, we don't talk about putting on the gloves properly. We don't talk about using the drapes. We don't talk about sterile technique with the catheter, and so forth. So all the infection control procedures, you are so focused on where to put the needle that the infection control things that are supposed to be accomplished don't happen. So when the process is changed, that before you go to the bedside to actually place the line, there is separate training for the infection control. Place the drapes this way, hold the catheter this way to keep it sterile, put your gloves on that way. When those things are accomplished and then you go to the bedside and teach how to do the procedure, there is a 300 to 1,000% decrease in the number of infections, line infections that occur. So these things are simple to do, but can have enormous impact and enormous effects on the patient to make things better. We also need to reduce the inefficiency. So you wear a pager and you go to the bedside. The fastest way to make your pager go off or your mobile phone to ring is to take it with you to the bedside while you do a procedure. While you're doing this procedure, I promise you the pager will sound or your mobile phone will ring. Or nurses with other patients will come over to talk to you while you're doing the procedure and say, Did you know that the patient in bed 8 has low blood pressure? So now you're talking like this, and you're turning away from the patient, and you're not paying attention to the tasks at hand. So something as simple as hanging up a sign that says, "Procedure in progress, do not disturb," and then handing the pager and the telephone to someone else away from the bedside where you're performing the procedure. These simple mechanisms have reduced the complications and the infection issues that occur. So very simple things that do not require much expense, but can make a very big difference. So there's other things that you can do, and everybody wants to build a checklist. Soon there will be a checklist for everything. So this way, you can't accomplish anything. You can't get anything done because you're too busy reading the checklists. So these things are important, but only for the things that make the biggest difference. There shouldn't be a checklist for everything. And these things need to be short and to the point, large print, not very many lines, simple instructions. They have to be very clear and they have to be very short with what you do. So an example of a checklist, if you're going to intubate a patient, that attached to the laryngoscope handle itself with a piece of tape is the checklist. And on this checklist, it tells you the 3 or 4 things to make sure that you know that the patient that you're about to intubate is not a difficult airway, does not have a history of being difficult to intubate in the past, or that their anatomy is going to make them difficult before you ever push any drugs, before you do anything to the patient. It's easier to stay out of trouble than it is to get out of trouble. These checklists are not just for nurses and doctors. It can be helpful for the housekeepers. Who cleans the ventilator when a patient is now extubated? Who cleans the bed after a patient with pneumonia leaves the intensive care unit? Do you have a protocol? Do you have a checklist so that this always happens the same way, that it occurs properly, that no steps are missed, and that you know for the next patient coming, the ventilator or the bed or whatever else is clean and ready for these patients? The same is true for those that take x-rays, for drawing blood, all of these things. So there's other things with human factors engineering that are out there that we can also pursue, and some of these are listed on this slide as well too. I think one of them to highlight is the use of ultraviolet light. Ultraviolet light kills bacteria and can be used to sterilize. In Bach Mai Hospital in Hanoi, we've also been using ozone generators to help with better infection control too, with water, to hyperozonate water so that we can use this to actually kill cell surface or surface pathogens, not just bacteria, but also viruses and so forth. So let's talk now about how to improve hospital efficiency. This is also a big problem. Many intensive care units say, we don't have enough beds. We have more patients than beds, and somebody always needs to come into the ICU. But there's no place to put them. There's no open or available beds. But what we have learned is not that there's not enough beds, but for the majority of the hospitals, it's the efficiency and how we use these beds that makes the greatest difference. So how do we study our processes so that we can improve our efficiencies? And that's what I'd like for us to talk about. So we have bottlenecks. Here's a typical road in Vietnam, only it would be scooters that you can see on your left-hand side of the slide. And you can see that there are bottlenecks. Places where things narrow down, that slow down the process and the flow. And where are those? We will see patients that are in the emergency department that need to come to the intensive care unit, but there are no beds available in the ICU. So we say the bottleneck is the intensive care unit. But what we find in many hospitals that the bottleneck is actually not the intensive care unit. It's the next level of care, the step-down unit or the ward where there are no beds, and so you cannot move patients out of the intensive care unit. So if you want to fix the problem in the emergency department, while you may look at the intensive care unit, for many hospitals, the problem is actually in the ward and not the ICU. So this is what this would look like. All the ICU beds are full, the intermediate care unit is full, and now there's a patient, 3 patients, in fact, that are scheduled for surgery, and we need a bed for these patients. There's also 2 patients in the emergency department who've just been intubated and also need ICU beds. So now you need 5 beds, but everything is full. So what are you supposed to do for these patients? How do you get past this? Well, I describe this like trying to turn a cruise ship. You need to know where you're going, not when it's time to turn that, but 10 kilometers before you get to the place where you turn the ship. It takes that long to turn it around. And the same is true for managing the efficiency and the utilization of ICU beds. If you wait until there's a problem, until there's no beds, you cannot fix this right away. And therefore you cannot deal with all those patients that need beds. You must start sooner. So let's talk about this. This is what's referred to as hospital throughput, and how can we improve this? So here's the way it looks. And if you look from the left-hand side of the slide to the right-hand side, you see that the patients that come to the intensive care unit are typically the sickest at the beginning of their hospital stay and towards the end of their hospital. And they come through and through the different levels. But this is what you see. When it's time to bring the patient to the intensive care unit from the emergency department or wherever, there's many calls. We're talking about bed availability, who's the doctor, did that person say yes, are there other tests that need to be done, and so forth. So all of these things happen before the patient even comes. Then once they get to the ICU, same thing happens. More phone calls, more delays, more discussion about bed availability, who's responsible. And now you want to move to the next level, same issues. Down to the ward, same issues. And even when they leave the hospital, same issues. Is the family ready? Who's going to do this? Do they have the medications? So every step along the way, problems occur. Same ones that we see. But the problem with this is we've built a system that depends on the individuals. I can't move this patient until I talk to the doctor and the doctor answers these questions and gives me approval, until the doctor says, yes, it is okay to move this patient to the ICU. The communications are not protocolized. The way we hand off patients from one provider to the next provider is not well structured. All of this results in delayed decision making, and so we have delays that occur from the system. So if we take that diagram that I showed you from the emergency department to the ICU, to the step down, to the ward, to the nursing home or to home or wherever the patient may go to the next step, there's no callback and all of these things happen. So there's a 6-hour delay here, a 1-day delay there, more delays here, and so forth. And at the end, this patient spends an extra 5 days in the hospital for this example because of these delays. It's increased costs. It's other patients that can't get into the system. It's less people through the system, less patients that are cared for, and so forth. So these delays have very big problems that they cause for us. So demand management, let's talk about that. That's the first term you see at the top of the slide. Demand management means you're dealing with things now. Somebody calls from the emergency department and says, I have a patient that I've intubated. This patient needs an intensive care bed. And then you say, okay, I have no beds. I will start looking for a bed. I will make a bed, and then I will call you back when we're ready. That's demand management. That's trying to fix the problems as they develop. But then all of those delays occur. Where we want to go is demand forecasting. that we can see the problems before they become problems, and we fix them before it becomes a problem. So how does that work? So if you look at the emergency department and you break the day into 25%, from 6 in the morning until noon, you can break this in half. You can break it into thirds. It doesn't matter. It's just that you break it up. But for each of these hour intervals, and you do this at the emergency department, the intensive care unit, step-downs, wards, all of these different areas, look at the days of the week. How many admissions? So let's just say we've learned from looking at a year's worth of logs of how many patients come into the ICU that every Wednesday between 1,800 and 2,400, we average 3 admissions. Some Wednesdays it's more, some Wednesdays it's less, but on average it's 3 admissions for this time period. And you can do this for each of these different areas and know. Then you can predict, okay, today is Tuesday, my ICU is full, tomorrow is Wednesday, I know tomorrow I'm going to get these admissions. So you can start working on what your needs are going to be for tomorrow today. This is the concept of demand forecasting. Another piece of this is trying to identify which patients need to stay and what patients can go. So a simple way is just like a traffic light. It's a green light, a yellow light, or a red light. A red light means this patient is very sick, they're still intubated, they're on a ventilator, they have vasopressor drugs in use. This patient is not ready to leave the ICU. We don't need to talk about this. The yellow patient means this patient is almost ready to go, but remember where we made the list of the care plan with the 3 things? This is where this comes into play. And you say, this patient is ready to go when these 3 things are accomplished and they need to be done over the next 24 hours. And a green patient means these things are all finished, they're ready to go. So you can decide every patient, this one's green, this one's yellow, this one's red, and then you know who to move. But not only that, we'll come back to Wednesday. On Tuesday, you are looking at the yellow patients and trying to fix and advance the care plan on the yellow patients so that by Wednesday they're ready to go, because you know you're going to get these admissions that we have forecasted will come to the ICU. So this is how we fix this. The other thing that's a big problem is looking at the intermediate care unit, away from the ICU where patients go next. Are there enough beds? And many times, to fix the ICU problems, you may actually decrease the number of ICU beds and make more intermediate care beds to help fix this problem. So if you want to address the throughput and the resource utilization issues, you have to accurately triage the patients and match them to the unit. So if a patient comes in and they're not that sick, but there's no beds in the intermediate care unit, so we'll just put them in the intensive care unit, you're not fixing any problems. You may make a solution for right now, because now the patient has a place to go and they're no longer in the emergency department. But for tomorrow, now you've made 2 problems that you have to deal with. One for this patient and one for the one in the emergency department that now needs the ICU bed, that there's still not a bed because you put a different patient in them. So that means that the decision-making criteria of which patient goes to which bed should be consistent and predictable in all units. So what does that look like? How do we know how we do this? So the first rule that I talked about is no ICU patients in the step-down area, in the intermediate care unit. Having the patients supervised by on-site ICU teams. How you do handoffs, palliative care services. In Vietnam, this is something of an issue, but in the United States, it's a big problem. We have patients that are brought to the intensive care unit who have terrible diseases like terminal cancer, who there is nothing we can do. This patient is dying, and we cannot stop the process. And yet, the patient and the family are not ready to accept the fact that they're going to die. And they say do everything, so we put these patients in the intensive care unit and try to deal with the problems there. But this creates other problems for us. So we will summarize now as follows. The first is, if you want to make changes, as we said at the beginning of the talk, education is not enough. You can't make signs, you can't have classes and fix these problems. You must change people's behaviors. You must change their attitudes. You have to change the processes so that bad things cannot happen. You have to understand human factors engineering and use these techniques to help you, whether it's rearranging rooms, where it's where you place alcohol jars of alcohol gel and so forth, all these kinds of things. It's understanding the psychology of where things are. So thank you very much for your time. I appreciate this. Enjoy the rest of the conference.